Okay. So what we're going to talk about today is part of chronic care management, which is kind of the umbrella term for this benefit that Medicare has for its Medicare patients. And we're going to talk specifically about principal care management. The first slide that we have is just our standard disclaimer. Our information is as accurate as we can make it as of today, but Medicare rules and regulations do change often. The Medicare rules and regulations are going to be the final determinant of coverage for the Medicare service itself. We'll respond to the questions that you submit. I have a friend and colleague of mine, Mary Muko, who will be watching our chat function. And once we're done with the presentation, then she will let us know those questions. We'll respond to those questions based on the information you provide to us and then the rules and regulations on principal care management. CMS does prohibit recording of this presentation for profit-making purposes. So if you are recording this presentation, we do ask you to stop at this time. Our goal for this presentation is to allow you and provide to you information on principal care management. This is a fantastic benefit from Medicare for you to provide absolutely wonderful care to your patients. And using the structure of principal care management under that chronic care management umbrella will really allow you to receive payment for some services you may already be providing to your patients. So what we're going to talk about today is kind of the reasons behind chronic care management and why this is such a benefit to your patients and to yourselves. Then we're going to talk about just a real brief overview of chronic care management, and then we're going to dive into the principal care management specifically. So why are we doing this? Well, if you look on this slide up on your screen right now, you can see that we have very high percentages of beneficiaries who have 2 or more chronic conditions. Well, patients who have the more chronic conditions, number one, are eligible for this, for chronic care management itself. And then there are also patients who are going to be needing more care. Through the use of chronic care management and specifically principal care management, one of the things that we can do is to really concentrate on the patient's condition and what they need in order for their quality of life to increase, hopefully, for them to address some of their health conditions. And so, like I said, as you can see, we have a pretty large percentage here. So why do we want to do this? Why is chronic care management so important? Well, for patients, it provides a whole different approach to care. It's more holistic, looking at kind of the entire patient and what's going on with that patient, even if you yourself is not treating everything, but it's looking at everything that's going on with that patient. It takes a much more proactive approach where the information is trying to prevent hospitalizations, emergency room department visits, and prevent crisis situations if at all possible. And then you want to concentrate on the resources and things that you have. And of course, it's also shown to be beneficial in lowering a patient's out-of-pocket expenses by those fewer emergency room visits and fewer hospital stays. The general coinsurance amount a patient is responsible for chronic care management is anywhere from $12 to $20 each time you submit for the principal care management or the monthly care management service. The deductible amount for a single hospital stay will pay for close to 5 years of that. For the provider community, why would you want to do this? Well, you can be reimbursed for work that you're probably already doing, especially for those patients who call your office a lot, who want to talk to the nursing staff a lot. Using this structure and going by the Medicare rules and regulations on this will really allow you to receive reimbursement for those services. There's less fragmentation of healthcare. And what we mean by that is in doing this service, you're working with the other providers and practitioners who are providing care for that patient. And by using chronic care management and principal care management, you kind of get everybody on the same page with that. In addition to that, providers have told us that they have more time for in-person visits when their patients transition to chronic care management. Now, that doesn't mean that you won't continue to see those patients in person as needed, but it also takes some of that burden off. And then there's more appreciation for the skills of your clinical staff. Chronic care management and principal care management is generally a non-face-to-face service, and it is generally provided by your clinical staff rather than by your physician or practitioner. And then it allows for your expertise to go towards some additional patients. Now, there are some challenges to beginning this. One of those is identifying the patients that can be part of this particular program. The other listed here is the Area Deprivation Index. And this is an index that is available for you, and it identifies areas where patients are really underserved. And so the patients who kind of really need this care are really kind of the ones who are not receiving this. Other challenges, recording the time that you spend on that patient, and we'll talk about that a little more. Billing and documentation, we'll also talk about that. You need to have the staffing in place, your clinical staff in place in order to provide this. And then some of your electronic health records may not be as conducive to recording all of this information as others. The providers that we've talked to, though, who are providing these services, indicate to us once they get over that kind of initial hump, and that's how they described it, in getting all of their workflows and their systems and everything together, it's really kind of smooth sailing from there. And their patients are very appreciative of the service that they're receiving. The physicians and practitioners providing a general supervision rule or general supervision over that clinical staff can really trust that clinical staff in order to provide this care to their patients. So what are some best practices? Well, you want to start small. Look at a subset of your most ill patients. You also want to make sure that you have your internal staff on board with this, your providers, physicians and practitioners, your administrative staff, your executive staff, and then of course your clinical staff. You want to accumulate the resources. This could be professional society toolkits. There are multiple toolkits for chronic care management out there. CMS does not endorse any particular one, nor does WPS, but you can use those toolkits to kind of help you get over that initial hump. And then you want to look within your communities. What are resources you have there? Do you have a Meals on Wheels program that can help a patient with better nutrition? Do you have transportation providers who can help the patient to get to their physical therapy appointment or their appointment with your office, etc.? So how will you know that you're really making a difference? Well, it starts with your relationship with that patient, in having a conversation with that patient to start this service, which we'll talk about in a second also. And then the data is important because of the story it tells. The data that we have evaluated in looking at chronic care management services has really shown a drastic decrease in emergency department visits and in inpatient hospital stays. So this is just some general information on chronic care management. On the left-hand side of your screen is chronic care management or complex chronic care management. On the right-hand side of your screen is principal care management, and that's really what we're going to concentrate on today. You'll see there that it is a single high-risk condition that the patient has. And then your second bullet point defines that. It's a condition expected to last at least 3 months or until the death of the patient. This condition then places that patient at high risk of death, acute exacerbation, functional decline. And then, as part of principal care management, it is also going to require frequent adjustments in medication for that patient, or that patient has had an exacerbation of their condition, either resulting in a hospital stay or the fear of the patient having to go into the hospital, or the management of that patient's condition is really just unusually complex due to the comorbidities that the patient has. So you can see here the patient has a significant risk of hospitalization. Changes in a patient condition may result in a referral. Generally speaking, and this is just a general statement, specialists are going to do principal care management probably more than primary care practitioners would do. It's not restricted to only a specialist. A primary care practitioner can do principal care management also. But when you get into principal care management, again, you have either had that exacerbation of that patient's condition, or you have the unusually complex patient because of the additional comorbidities that they have. The other thing to remind you is that for a chronic condition, Medicare does not have a list of these are the ones that are applicable. It really just has to meet that definition on that previous slide. So who are the providers who are eligible for this? Well, those are listed there for you on the slide. Your physicians and non-physician practitioners. We did have a pre-submitted question as to whether or not a podiatrist would be considered a practitioner or a physician actually for this. And the answer to that is no. The information provided by CMS in the rules is that generally for the physicians, we're looking at the MDs or the DOs, not chiropractors, not podiatry, etc. You'll also notice here that rural health clinics and federally qualified health centers can provide principal care management services. Again, as we mentioned, these are generally provided by your clinical staff under the Incident 2 guidelines. Now, there's a lot to Incident 2 guidelines, but what we're basically talking about is that there's an employment relationship between that clinical staff and the billing practitioner. So this can be a W-2 direct employee of either the physician or the non-physician practitioner or that entity. It can also be some type of contractual relationship, such as you could be contracting with a care management organization, but you would need to have those contracts and things in place. You could also be contracting with clinical staff from your local hospital to provide after-hour care. That would need to be identified within that contract. And then it is under general supervision as opposed to direct supervision. So again, on this slide, just something to think about. It can be the specialist, can also be the primary care provider. And then the something to think about is that care fragmentation. In providing, whether you're a specialist or a primary care provider, in providing principal care management services, you will be incorporating information from other practitioners, should there be other practitioners involved, into your care plan. and then sharing your care plan with those other practitioners. Again, it leaves everybody kind of on the same page. The patient has a greater idea of what they can expect, and a greater idea that everybody is working together on their care. Here we have just a slide concerning the Incident 2 guidelines themselves. Clinical staff should have access to the patient's medical record. And what we mean by that specifically is the care plan, even outside of normal business hours. That next bullet point, the clinical staff must be physically present within the United States. There are care management organizations, as we mentioned earlier, out there, and if you choose to use one, that's certainly your choice. Medicare has nothing to say about that. The only thing we do have something to say about, though, is that Medicare does not pay for services outside the United States. And so, therefore, that clinical staff that are helping you to provide the principal care management services have to be physically in the US. And then the next bullet point is just a link for you to the CMS Internet Only Manual that has all of the instructions and more detailed information on the Incident 2 requirements. So let's talk about some of the service requirements. Well, the first thing is the patient does have to consent. It's not something you can do without asking them for. That consent can be verbal or written, and it can be gathered by either the clinical staff or the physician or practitioner. There's certain information that has to be gathered in a certified electronic health record, and we'll talk about that in a second. You do have to manage care transitions, which means they're coming out of the hospital, out of the emergency room, out of a skilled nursing facility, something along those lines. And then the patient has to have 24/7 access to clinical staff. So there's all kinds of ways that you can do this. You can have a person who is on call, and a telephone call that a patient makes to your office goes directly to that person. You can have a person on call so your patients can use your portal and you have someone actively watching that portal. You can use an answering service as long as that answering service is aware that you have patients who are part of principal care management and that they have the instructions on how to get that patient to a clinical staff member. So, some of the items that you would want to discuss, again, is that patient consent. You want to remind them that um, they will have cost sharing that goes along with that. Only one practitioner can submit the chronic care management or complex chronic care management services. Other practitioners can submit the principal care management. So you couldn't submit both the CCM and the PCM in the same month. But if another practitioner is submitting CCM, you can still submit the principal care management services. You want to let the patient know how to access that clinical staff. And then the last bullet point, the patient can revoke this if they choose. That revocation is at the end of the month. And if you have provided services during that month, then you can still go ahead and bill for those services. Now, some patients will need to have an initiating visit prior to beginning your chronic care or your principal care management services. And you can see there it's new patients to your practice, and that's to you or a member of your same group with the same specialty, or patients who have not been seen within the previous year. And then under that are the encounters that can be considered that initiating visit. The next slide has information on comprehensive assessment and care plan. During that initiating visit, and it's only during that initiating visit on the same day of service. If your practitioner is doing an assessment of that patient's care, a comprehensive assessment, and then is developing that care plan, then there's another procedure code that you can submit in addition to that initiating visit. And you can see it there, the G0506. Now, there's no time attached to this procedure code. However, you do have to have the documentation to support that comprehensive assessment of the patient and then the development of the care plan itself. In the electronic care plan, you want to make sure that it's patient-centered. And so what we mean by that is you could have Susie, who has had an exacerbation of her diabetes. And you could have Bill, who also has had an exacerbation of the diabetes. Bill and Susie are not the same person. Bill and Susie don't have the same environments, they don't have the same other health concerns. So you want your care plan to be as specific as possible for that patient. Here's a list of the things that have to be gathered through that certified EHR. This is patient demographics, the problems. For chronic care management, it's all problems. For principal care management, it is that principal chronic condition and any additional problems that directly feed into that. You need to record the medications in that certified EHR and then medication allergies. Other information should be electronic so that it is available to your clinical staff either during or after office hours. So let's talk about the information that's required in the care plan. Well, number one is going to be the problems. And again, for principal care management, it's that single high risk chronic condition, and then anything that feeds into that chronic condition. You need to identify the patient's prognosis. Now, a lot of times when we think of the word prognosis, we really kind of equate that to life expectancy, and that's not what we're talking about here. When you're talking about prognosis, you're talking about this is what we expect. For some of your patients, it could be a life expectancy. For others of your patients, it's going to be identifying for them what you're expecting to happen with that single high risk condition. You also need to identify the goals that you have for the patient, and these need to be measurable goals. So what we're talking about here could be you want the patient to be able to walk from one end of their house to the other without totally losing their breath. So that's the goal that you have for them. You want their A1C to be under 6. That's the goal that you have. The next thing that we have is cognitive function. If you are evaluating your patient and based on what they're telling you, what your physicians and practitioners are observing, there is no cognitive dysfunction, you simply document that. If you believe there could be a cognitive dysfunction, then you need to use a peer-reviewed tool in order to assess that. And the tool that you used and any results from that testing will be as part of your medical record. You want to look at the patient's functional limitations. Can they raise their arm up high enough to be able to wash their hair? Can they bathe themselves? Can they walk from one end of the house to the other? That type of thing. And so that needs to be documented. For the single chronic condition, you need to identify symptoms that the patient may be having from that disease or illness. And then what are you going to do about those? That could be an additional medication. It could be maybe another medication is causing some of those, etc. And then you want to look at planned interventions. For chronic care management, this would include all of the preventive services. For principal care management, you can certainly include those. but it's not required. So what you're looking at for your planned interventions is going to be, okay, Susie, I want you to have another A1C 4 months from now, and that's part of your care plan. So 3 months from now, you're going to remind that patient, hey, don't forget, you're going to have this A1C test done. And then after they have that A1C test, then you can talk to them about the results, about what that means for their care. And then, of course, medication management. Medicare beneficiaries, especially those with chronic conditions, can be on a lot of medications. One piece of documentation we looked at that was supplied to us by a provider, the patient was on over 30 different medications. So as part of the care plan, you want to be looking at how those medications are interacting with each other. Are they the best choices? Are they causing additional symptoms? Are they causing the cognitive dysfunction? And then work with not only what you may decide the patient needs to be on, but then also anyone else who is part of that patient's care. If the patient is also receiving chronic care management from their primary care provider, a lot of that information will be directed between the two of you. Then you want to be looking at the patient's environment. Are they homeless? Is their home a safe place? Um, if they have breathing problems, is there a lot of mold? Is it air conditioned? Is there adequate heating, etc.? Excuse me. Then you want to look at your caregiver assessment. So the first question you would have is, do they need one? Well, if they need one, do they have one? If they have one, is that person physically and mentally capable of assisting them with the care plan that you are developing and providing the services that that patient needs? And then you want to look at social services. And these could be things within the community, either that the patient is already utilizing or that they could be utilizing in order to increase their quality of life. We've mentioned some of those: Meals on Wheels, transportation services. Is there a grief organization or grief counseling available for a patient who has just lost their spouse, etc.? You want to update the care plan as needed. And this is a question that we get quite often. Are you updating the care plan every time you provide this service? And the answer to that is not necessarily. When you're doing this monthly service and you're following that care plan and having discussions with the patient, looking at test results and all of those kinds of things, unless you're changing that care plan, then you're simply doing the care management service. If you update the care plan, then you need to share that with the patient or caregiver, and then other practitioners who are also involved in that patient care. And then you do need to update that care plan at least yearly. So a care plan for principal care management, again, it is going to be chronic disease specific. So it's all of what's going on with that patient that goes into that chronic disease that you're actually treating. Again, your preventive service and planned interventions are going to go along with that chronic disease, and you're going to be coordinating along with that primary care provider and others who may be part of that patient's care. Again, that has to do with that care fragmentation. If everybody's talking to each other, then everyone's going to be more than likely to be on the same page, and therefore the beneficiary is not getting conflicting information. They're not getting medications added without kind of everyone knowing the same information. So the following is the actual monthly care management service. Um, there's a lot that goes into that. You want to document your activities. Your activities can be your contact with the patient. Depending on your patient and their medical needs, you could be contacting that patient once a month. Probably for patients receiving principal care management, you're contacting them a little more often than that. So you're going to document the contact. I spoke to Susie today. Here's what we talked about. Here's information I gave her, information she gave me. Here's how long it took to do that. And then you're going to document that again within your records. The time that you spend documenting that, that's part of the time for this procedure code. If you're having an outside conversation with another practitioner, then document that time. If your clinical staff is calling another office's clinical staff to get test results, to get notes on the last time that the patient saw that practitioner, etc., all of that is work that you are doing for that particular patient. Capture that time. Don't leave any of that laying on the table. And then you want to identify who provided the service. As we talked about earlier, generally speaking, it's going to be the clinical staff, but your practitioner can also be part of that service in providing that non-face-to-face service. And then the best practice is to submit at the end of the month. That way you can capture all of the time that you have provided to that patient during that month. Now, for care management, principal care management specifics, you cannot submit with any other care management within the same month. So we talked about that already with um, um, chronic care management, complex chronic care management. This can also include other services like hospice supervision, home health supervision, ESRD, end-stage renal disease assessments, etc. And then if you are uh, provided surgery for that patient, then principal care management cannot be provided during the global surgery period by that surgeon. So here are the procedure codes. On the left-hand side of your screen are the principal care management procedure codes. You can see the codes there, the 99424, first 30 minutes provided by your practitioner. Now, a couple of things on that. Number one, it has to be at least 30 minutes. There is no rounding with this. And then number two, it has to be practitioner time in order to use that procedure code. And then you can see the 99425, which is each additional 30. And again, that has to be met in full. There are also two procedure codes there for you for your clinical staff. Now, one of the things to keep in mind is you're going to bill one or the other. You can't bill both practitioner and clinical staff in the same month. Your practitioner time can feed into your clinical staff time, but your clinical staff time cannot go towards your practitioner time. So for an example, if your practitioner has 10 minutes of care that they have provided to that patient that month, and your clinical staff have 20 minutes, then you can bill that first 30 minutes clinical staff procedure code, that 99426 procedure code. And then on the right-hand side of your screen is the procedure codes and instructions for uh, chronic care management and then complex chronic care management. So some additional information, a reminder there, practitioner time can count toward clinical staff time, and then the time must be met in full. That last bullet, don't submit if patient is attributed to you as part of a CMS program. Currently, that is generally going to be through primary care first. If you are a primary care first provider, then you don't bill separately for chronic care management, complex chronic care management, or the principal care management. And then we also have information here for you for rural health clinics and federally qualified health centers. They have a different procedure code that they would submit. And you can see there up on your screen. And that does include all three: chronic care management, complex chronic care management, and then principal care management. For RHCs, the comprehensive assessment procedure code is not available. And then this is paid to them under the non-facility fee schedule amount, as opposed to being part of their all-inclusive rate or part of their prospective payment system rate. So that's the information that we have to provide to you on principal care management. We have a lot of different resources available for you. We have a very comprehensive article that is available on our website called Chronic Care Management, and Principal Care Management is part of that article. In addition to that, we have multiple YouTube videos. We've got some short videos discussing different pieces of chronic care management. And then we have also encores of previous webinars that we have done on chronic care management services. So if we're not able to get to all the questions today, there's the email address again for you so that you can submit follow-up questions and we will respond to those. Depending on the number of questions that we receive, we may respond simply directly to the person who contacts us, or we may do an email response back to all attendees for today's presentation. The next thing that we have up is a link to a survey for this presentation today, and then also a QR code where you can use with your smart device in order to take a survey. We really do encourage you to take a survey. We want to hear from you. We want your opinions, your information on the presentation today. In addition to that, there is information where you can suggest topics for us to do future education. We want to hear from you on that also. The other way that you can take the survey, once we end this presentation today, you will receive another email from us you receive a pop-up on your screen. It has a little yellow triangle at the top, and then it has a continue button. This is not spam. It's just WebEx telling you that you are leaving the WebEx site and you are going into that survey. So you can use that to take the survey. And then following the presentation, sometime this afternoon, you'll receive an email from us thanking you for your attendance today, and then also providing you another opportunity to take the survey. I think you can tell we'd really appreciate it if you took the survey. So Mary, I'll go ahead and leave this up here for just a second. Do we have any questions?
Alan, I have received no questions so far. And for today's chat, we're doing things a little bit different. When you need to send a question to us or you want to send a question to us, we would like you to use everyone. There is no option today in this particular webinar to send your question to all panelists. Instead, we'd like you to send your question to everyone. That option is available. And I'll be happy to read the question off then to Ellen. But at this time, Ellen, there are no questions.
Okay, thank you, Mary. The basic difference between principal care management and chronic care management or complex chronic care management really has to do with the intensity of the services and the intensity of that single chronic condition that the patient has. Um, I encourage you, if you are a specialist or a primary care provider for that matter, and you really to take a look at the patients that you're treating and that you're seeing on an ongoing basis to verify, to look and see whether or not these patients will qualify for this service. As we mentioned earlier, um, chronic care management, the whole umbrella, encompassing chronic care and then complex chronic care and principal care, really is an added benefit for you. Take a look at the information that we provided. Take a look at that article that we have available on the website. Don't leave money on the table. If you have patients who will meet these qualifications and you can provide this service to them, do so so that you can receive that reimbursement. Okay, Mary, anything else?
And there are no questions.
Okay, I have just one other thing to kind of remind you about. In the description, the CPT description of the procedure code itself, I got to find, here it is. Part of that description says the condition requirement requires development, monitoring, or revision of a disease-specific care plan. The condition requires frequent adjustments in medications and/or the management of the condition is unusually complex. So the description of the procedure code really supports the information that I have provided you here today. So Mary will ask one last time for any questions.
There are none, Ellen.
Okay. Then I want to thank everyone very much for your attendance today. Um, hopefully you'll be able to take this information back to your physicians and practitioners and then be able to start submitting these services. With that, then we will end the webinar. Have a great day, everyone.